Get started. Let's begin today's program entitled The Role of Family Planning in Improving Maternal Health. My name is Sandeep Athala. I'm a senior program associate with the Environmental Change and Security Program, as well as the Global Health Initiative here at the Woodrow Wilson International Center for Scholars. ECSP, or the Environmental Change and Security Program, is 19 years old, and we look at the various connections between health, environment, livelihood, population, and security. Today's event is brought to you as part of our HELPS project, which incidentally stands for those health, environment, livelihood, population, security words that I just used. That's a 5-year effort, which is generously supported by USAID's Office of Population and Reproductive Health. The Center's Global Health Initiative works to address many critical and neglected maternal health topics and is generously supported by the Maternal Health Task Force as well as the United Nations Population Fund, or UNFPA. So you can see that both the projects that I'm involved with today married perfectly for this wonderful event that we have coming up right now. As many as you know, I see a lot of friendly faces in the audience. The Wilson Center is a formal memorial to our 28th president, the only president thus far to have achieved a PhD. And in his honor, we aim to bring the worlds of policy, practice, and academia together to gain a better understanding from one another. A note about today's meeting: we are being webcasted live, so when we do come to the discussion, I'd ask that you use a mic and introduce yourself and affiliation so those that are tuning in can hear you. And before I turn it over to our esteemed moderator, Sarah Craven, who's the chief of the Washington office of UNFPA, I do want to thank all the co-sponsors. This was truly a collaborative effort that includes CARE, Every Mother Counts, MSI, UNFPA, and USAID. So thank you, and Sarah.
It's a long walk. That's great. I'm Sarah Craven, and I just want to really thank Sandeep and the Wilson Center and Lauren in the back of the room for once again hosting us, and I'm just so delighted to see a full room today. I want to thank, there she is, Nomi Fuchs-Montgomery with MSI and her team. It was about a year ago that we did an event for the Family Planning Summit, and I think MSI and UNFPA realized that we like to have events in July. Just before you all go off on many of you for vacations in August, we were thinking this would be a great time to have some food for thought, and then we'll have a reception following so we can all have a chance to connect before we reconvene probably in the fall and move forward on all the work that we need to do together. I'm so honored and delighted to be able to introduce our first speaker, who's Dr. Maureen Norton, the Senior Technical Advisor in the Office of Population and Reproductive Health. I haven't seen Maureen in a while, and she may not remember that she was my first CTO many years ago when I was at SEDPA. So Dr. Norton is with the Bureau of Global Health at USAID, and she currently leads USAID's PRH Technical Priority, Healthy Timing and Spacing of Pregnancy. I can't think of anyone better who can really talk and really set the stage for us today when we talk about the key role that family planning has to play in improving maternal health. So Maureen, I'm going to turn it over to you, and thank you so much for joining us.
Thanks for that wonderful memory. Okay. Thank you, Sarah, and thank you everybody for coming here today and giving me the opportunity to talk to you about family planning as a maternal health intervention. And before I do that, I wanted to just set out for everyone a question that we often are asked, both by groups in the United States and groups in developing countries. And the question and the comment is this. These groups say to us, we understand that family planning is an intervention to prevent unwanted pregnancy. But how does family planning promote maternal health? How does family planning save women's lives? And our response to that question is simply this: family planning helps ensure that pregnancies occur at the healthiest time of a woman's life, and these pregnancies are wanted and planned. And when pregnancies occur at the healthiest times, women and their newborns are more likely to survive. Now, we've seen many research studies that set forth or identify the healthiest times for a pregnancy, and basically these studies are telling us that there's roughly 4 times in a woman's life that are the healthiest times for a pregnancy. And these times are after age 18 to prevent adolescent pregnancy, at least 24 months after a live birth, which means a birth-to-birth interval of about 3 years, and 6 months after an induced abortion or miscarriage. And these intervals can prevent rapid repeat pregnancies. And then we have new research coming out that shows that the healthiest outcomes occur if the pregnancy occurs before a woman is 34 years of age. And so this helps prevent advanced maternal age pregnancies. And then the 4th time could be timing and it could be spacing, but pregnancies should occur, the research is telling us, before a woman experiences 5 pregnancies. And those latter 2, the advanced maternal age pregnancies and the high parity pregnancies, the new research is showing that they are associated with increased risk of maternal death. So when pregnancy occurs outside of these healthy times, they're more likely to be high-risk pregnancies. And high-risk pregnancies, all of our studies are showing us, they're associated with a wide range of adverse maternal and newborn outcomes. So if there's one message we'd like you to take away from this session, it's that family planning can help prevent fertility-related high-risk pregnancies and in this way save women's lives. So we'll be hearing more about high-risk pregnancies in a video in just a minute. And I also wanted to say we are learning from our operations research studies that when women and men, and even religious leaders and community leaders, are counseled on the healthy times for a pregnancy, they understand this concept immediately. And the use of family planning increases in those intervention groups. And we have in the audience some of our partners who helped us develop those counseling and those educational approaches. So now I'd just like to turn and highlight in just a few minutes some of the family planning and the high-impact family planning approaches that USAID is using to improve maternal health. So one of the most important steps we've taken is really to try to target services to women with high unmet need for family planning, and this would include postpartum women and post-abortion women. For example, studies show that 95% of postpartum women either want to delay childbearing for at least 2 years or end childbearing altogether. But 70%, that's an astonishing figure, 70% of postpartum women are not using family planning. So we have seen how important it is to get family planning services to women who've recently experienced childbirth. But in 2005, we asked one of our researcher colleagues to try to identify integrated postpartum care, and I see her sitting right there in the audience, Marge Kublinski. We asked her to find examples and document examples of integrated postpartum care, and her study only identified 5 integrated family planning, maternal and neonatal care programs in the developing world. Most of those were small, and none were community-based, so we knew we had a lot of work to do. She called the need for family planning the need for postpartum family planning or integrated care an urgent unmet need. So since that time, we are now pleased to report that we've been working on postpartum care, and we have about 20 integrated maternal and neonatal health programs in our 24 priority countries. With respect to postpartum, we have been working to develop a decentralized model to get postpartum care, and that we call that our PAC services, post-abortion care. It always includes family planning. We've worked to develop a post-abortion care model that's decentralized, that moves post-abortion care from the tertiary hospital to the health post. And we've been able to implement that model now in 4 countries. We hope to introduce it in additional countries. Now, in all of these programs, in both the postpartum programs and the post-abortion care programs, we've been working to introduce choice, increase the method mix, and introduce long-acting reversible methods of contraception. Why? Because these methods are highly effective, and the use rates for these long-acting reversible methods of contraception like IUD and implants are about 1 to 2% in our priority countries. Now, we're also working with our private sector partners to introduce other models, social franchising models, and mobile outreach with dedicated LARC provider models. And we're going to hear more about that in just a few minutes. To give women more choice, we're working to introduce a more balanced method mix, and we've introduced fertility awareness methods. This is the lactational amenorrhea method, the standard days method. We have made those methods available in about 5 to 10 of our priority countries, and we are now scaling up the SDM, standard days method, in about 4 countries. In research, we're testing approaches to end child marriage. And in our gender work, we've developed a male engagement model. It's called the Healthy Images of Manhood. And this model has been tested and introduced and implemented in 2 countries. And it's been highly successful in those countries. And it's telling us that women are more apt to be able to practice healthy behaviors when the male partner is knowledgeable, engaged, and supportive. Finally, in health systems, we have been working on an activity, an intervention that we believe has tremendous potential to accelerate a reduction in maternal and infant deaths, and that is simply by keeping the community health workers in place in those rural areas. We know in the countries that we work, very high percentages, i.e. 60 to 80% of women in the rural areas have never heard of family planning methods. So we're working on an incentive package, we're testing it. It's actually various incentive packages that we're testing that would aim to keep those rural workers working in those remote rural areas. So these are just a few, and it's a very cursory overview of the many ways that we're working to support family planning as a maternal health intervention. Now, I'd just like to close with a few words from a speech prepared by the USAID Zambia Mission Director, Dr. Susan Brems. And she titled her speech, "The Seasonality of Safe Motherhood." And she gave this speech to a community of male and female farmers in Eastern Province, Zambia. And Zambia, as you probably know, is a country with about the highest fertility rate in the world. It's 7.2, and it is increasing. And Zambia is a country where there are very high rates of adolescent pregnancy. So in her speech, she said, quote, "Seasonality means there is a time for most things. In farming, there is a time for the rains and a time for the dry season, a time to plant, to weed, and go to market. This seasonality gives a rhythm to our lives. If we do things out of season, plant too soon or too late, it disturbs the rhythm of our life and causes problems. And so there is a seasonality to motherhood. There is a time when it is safe and healthy for a woman to become pregnant, and there are times when it's not good. Let us commit here today to respect the seasonality of a woman's body. Our rallying cry should be, everything in its season. Births not too soon, births not too close together, births not too late." Thank you very much.
I'm going to get my workout here. Thank you, Maureen, so much for your very clear and very good overview presentation. We now are going to hear from Jessica Bowers, who's the Portfolio Director at Every Mother Counts. I am so happy to see Jessica. She has been with Every Mother Counts for a year now, or?
Close, yeah.
Yes, close to a year, but I had the great pleasure of working with her closely at the UN Foundation, and I was quite mourning her loss when she left, but so happy to hear that she is continuing that work in this important role. Jessica is going to share with us a video and then talk a little bit about the work that Every Mother Counts is doing in the field. So Jessica.
Is this on? Yes. Okay. Well, thank you, Sarah, for the very kind words. And thank you to MSI, Wilson Center, and CARE, and USAID for putting this together today. I have done nothing, so I'm very appreciative. I'm also very flattered to be up here with such an impressive group. Every Mother Counts is a big supporter of family planning. We see it as one of the lowest cost interventions with the biggest return, with the ability to prevent up to a third of maternal deaths. So very excited to be here supporting that. Like Sarah said, I'll just briefly set up the film and then just say a little bit about Every Mother Counts, since we're fairly new and a lot of people I know aren't familiar with us. But No Woman, No Cry, you're going to see the first 15 minutes of this film. It's the directorial debut of the Every Mother Counts founder, Christy Turlington Burns, who has been a long time health advocate and more recently maternal health specifically. So the film pretty much speaks for itself. The first 15 minutes just explaining Christy's background. So with that, I hope you enjoy it.
If I look familiar to you, it could be because I've been a fashion model for the last 25 years. What you might not know about me is that I'm also a mom. When the time came, I was ready and eager for a life-transforming experience. The labor itself was intense, but pretty much went the way I imagined it would go. Then, in what seemed like an instant, I went from feeling invincible to powerless. The midwife called for backup. They took my baby away, and I began to hemorrhage. I'll never forget the fear and panic of that moment. Fortunately, I got through it. But too many women around the world don't. I've since learned that hundreds of thousands of women die in pregnancy and childbirth every year, and 90% of those deaths are preventable. Over the years, as I've watched my daughter grow, I've continued to be haunted by these shocking facts and compelled to do something about them.
Usilie, mbona unataka kulia? Umesikia Usilie mama wangu, sawa? Usiogope manake utanini, tutakusaidia sawa Naona unaanza kunini kama unayetaka kulia, sawa mama? Usiogope kabisa, tutakusaidia mwanangu, sawa
Janet is over 9 months pregnant with her third child. She's made her way to the nearest clinic, hoping to deliver there.
Sasa tutakuangalia tena maendeleo yako kwa muda huu. Uko na manesi,
umekula lakini
madaktari wako.
Umekula?
Nakunywa chai.
Basi
Chai tu.
kuanzia asubuhi.
Sasa Janet, kama usipokula, je, utapata nguvu ya kusukuma?
Nakula mkate kidogo.
Inatakiwa ule ushibe upate nguvu ya kusukuma mtoto Janet. Bila hivyo mtoto hatoki na hutapata nguvu ya kusukuma. Umesikia Kwa hiyo inatakiwa ule ushibe vizuri. Sawa? Au chakula unacho au huna chakula?
Sijaleta chakula.
Janet was at the clinic for a full day and night. There are only 4 beds. The nurses needed to make room for other patients arriving. She had no choice but to go home. And it's a 5-mile walk.
Wale wengine wawili wengine Mungu alionisaidia hajaninyima kutembea, nimeenda tu mzuri. Nikawa huyu mtoto tu ndio ananisumbua, sijawahi pepa mimba kama huyu. Maana ananisumbua kuna saa ambaye ananinyima chakula, saa nyingine ananinyima kulala, saa nyingine anifaa kufanya kazi yangu, nakaa tu hivi kama mjinga kwa maana sina nguvu tena, ananisumbua. Na hofu kwa maana sijaona mtu hapa anaweza kunisaidia mimi, kwamba kuomba Mungu akinipa nguvu nitaenda hospitalini, akiona uwezo sina na kama Mungu ananisaidia. Watoto naona mahali umewakuta sina chakula, sina nini. Sasa nakaa hivi kitu ambayo una. Sasa nitaenda huyo maudibeni, nitaenda kurudi na miguu, nitaenda na miguu maudibeni, nirudi na miguu bila kulipa ndeni ya hospitali, sina daiwa pesa. Nitaendaje?
After a long day without any food to eat, Janet's labor ramps up. And now, the pain is even more intense. In desperation, she sets off for the clinic again.
Kitovu imezunguka labda kwenye kichwa chake, sasa inajivuta, inashindwa labda kushusha mtoto. Kwa mfano kama yule mama tuliyemzalisha juzi, ilikuwa tatizo karibu mtoto angeshindwa kutoka, maana yake kitovu ilizunguka mara 3 shingo ya mtoto.
Baba fariji waongoze watu wako, waongoze watu wako. Amina, haleluya, amina, haleluya, amina, haleluya.
The clinic has 1 midwife, 1 nurse, and only occasionally is a doctor available.
When I was a physician, human resource shortage was the biggest problem. I worked in a facility whereby I was the only obstetrician for 2.5 million people. And the other one is resources to do things properly in terms of lack of drugs, lack of equipments and supplies, and also that people are frustrated in the sense that they are overworked. And when you try to tell them to work more, I mean, you are stretching them too far.
Tunawarefa wakina mama ambao wako kwenye anti-riski, yani ana prolonged labor au bleeding au yuko mfupi au pelvic yake ni kidogo kwa kujifungua kwa hapa. Kwa hiyo huyu anatakiwa kwenda mbele zaidi. Maanake kituo chetu haiwezi. Inawezekana labda akapata operation, inawezekana labda akasaidiwa na madaktari zaidi. Sasa sisi hatuwezi, kwa hiyo inabidi tuwaambie waende. Kwa hiyo wanapokuja lazima umwangalie mama. Je, huyu mama ana uwezo wa kuweza kujifungua katika kituo changu? Huyu hawezi, huyu ni wa kwenda Mount Meru.
Mimi nilikuwa nakaa nikisikia mimi maumivu na nasubiri mtoto ambaye ningekuwa Mungu amenisaidia.
Aliletwa akisema ana maumivu. Kichwa hakijaingia wala membrane hakuwa na dalili ya kuonesha kwamba anajifungua, lakini alikuwa na maumivu makali ya mgongoni, alikuwa na maumivu chini ya tumbo. Kwa hiyo ilibidi tumpumzishe ili tuangalie hali yake, na mpaka dakika hii hali yake bado hairidhishi. Kwa hiyo tunaamua kwamba tumpeleke Mount Meru. Uchungu unaongezeka? Sio kama jana usiku?
Ndio kutembea siwezi. Lakini sisikii msifuru. Sikia tu uchungu wa kawaida.
Wa kawaida. Kwa hiyo uchungu nani wa kuweza kunini hakuna. Sasa, je, kama tukihitaji kukupeleka, utakubali tukupeleke Mount Meru?
Ndio mnayo vile mtu anifanya kwa maana. Ndio mnayo vile mtu anifanya, ndio madaktari.
Sasa mume wako hajaja mpaka saa hizi, itakuwaje? Ili aweze kukusaidia kwa ajili ya kupata usafiri wa kukusafirisha Mount Meru.
Si ampigia simu.
Maanake sasa kama itakuwa hivyo, sasa sisi tutakupelekaje basi Mount Meru? Maanake ni lazima upate gari uende naye kutokana na hii hali ulionayo. Una hela ya kwa ajili ya kwenda hospitali? Kabisa.
Janet's labor is not progressing, and the threat of death for both baby and mother is palpable. With no money to pay for food or transport, the nurses ask us to help. We arrange for a van to take Janet to the nearest hospital, an hour away. The van ride costs $30. More than Janet's family takes home in a month.
Madina yawa kinogoli kamukira nabo. Tiama mutana samukire toro. mene kwe wengisha ngane sidar manan kangana lele manan niki ngamwake nikide turake.
When a woman dies, there are far-reaching effects to the whole family. In a country like Tanzania, women are the ones who do most of the work in the rural areas. They are the ones who fetch the water, they are the ones who do the farming, they are the ones who take care of the families more than the men. And if they die, then it's a disaster for the whole family.
The staff determines that Janet is exhausted and dehydrated. They quickly work to induce her. Three days and many miles later, she gives birth to a healthy baby boy.
Mungu akiniinua mimi watoto wangu nitaweza kuwaweka, yaani kwanza wapate elimu kwa maana mtihani. Maana wale watu wangekuwa hawajasoma wangeniokoa mimi.
Just as Janet is making her way home, a frightened 16-year-old arrives at the clinic in labor.
Sawa, nisikilize mama. Huyu mtoto mwili wake, yaani urefu ni mfupi. Sawa, upana wa nyonga ni mdogo kwa kuzaa. Sawa vyombo hatuna hapa. Iliyopo nafuu kwenda Mount Meru. Usilie mama, unasikia
Nduko. Iyangara yekeli. Ngala yoma na mema yote. Kwade mama ya. Kwade. Kwade baba. Ngaka na nigi nderu ni dunya kwa. Ngo kutugaje.
The film goes on to then document the experiences of women in 3 other countries, Guatemala, Bangladesh, and the US as well. After Christy made this film, she got such an overwhelming response of people who wanted to take action, wanted to get involved, wanted to do something, wanted to learn more. So she founded Every Mother Counts in 2010 as an advocacy and mobilization campaign aimed at ending preventable maternal deaths and disability around the world. So we work to engage our audience with really sort of a light personal content that's aimed sort of at mother to mother, trying to capitalize on the universality of motherhood and pregnancy, and something that everyone can relate to, whether they're a mom or not. we try to portray it, the issue as a universal connecting issue that really can bring us all together. We're also seeking to show our audience both the problems and the solutions around the world. And we, as portfolio director, I manage a small set of grants that we direct all of the funds we raise into to really demonstrate these problems and solutions and put a human face on it. We're seeking to really address the major barriers to maternal health around the world, and that includes the U.S. I think a lot of people don't necessarily think of the U.S. as really having a problem, but we're actually ranked last among all industrialized countries for maternal health indicators. So we currently have grants in Uganda, Haiti, and Winter Garden, Florida. Which actually the project that we support in Florida is highlighted in the film as well. But through these grants, we're really seeking to tell a complete story and then engage people in ways that they can sort of connect with the barriers to maternal health. So for instance, one of the biggest barriers is distance, the distance a woman needs to walk or get a ride to get to a clinic. So for example, we raise funds through races, marathons, to really highlight distance as a barrier and show how people can get involved and to really show the issue. So I invite you to visit everymothercounts.org to learn more. We have all the social media channels, and I'm happy to answer any questions, and thank you for listening and for watching.
Thank you so much, Jessica. I think that's the second or third time I've seen the film, and I'm just so struck at how beautifully it gives sort of the real-time experience of seeing what a mother in Tanzania is experiencing. And I know for many of us who work in this area that may be not unfamiliar, but certainly for the American public and for policymakers to have that without being able to travel is very compelling. So thank you for that. I'm very pleased to now introduce to you Dr. Benjamin Schwartz, who is the Senior Director for the Health Equity Unit at CARE. In that role, he oversees CARE's multifaceted health initiatives across the reproductive, maternal, newborn, and child health continuum in nutrition and early childhood development, HIV/AIDS, and health programming in humanitarian settings. And I'm so delighted he can be here today. I think CARE does such an important job in not only doing the programming and the work on the ground, but also telling that story and advocating with policymakers. And so you really see that those two pieces are so key. So thank you for joining us, and we're happy to have you.
Well, thank you very much, and thank you for the opportunity to share the work that we're doing at CARE in family planning, how we're integrating that work with maternal health, and more broadly, how we're implementing and documenting strategies around working with women and communities in order to increase effectiveness. We all know that sexual, reproductive, and maternal health is critical not only to a woman's health and well-being, but also to reducing poverty and increasing social justice, which is CARE's global mission. Recognizing this, SRMH is one of 4 programmatic focal areas for CARE, and also one of 4 advocacy priorities and priority sectors for emergency response. CARE has SRMH programming in 41 countries, directly reaching almost 50 million women, which makes it our largest overall program. While our specific programmatic work varies between countries and according to context and donor foci, as well as opportunities for innovation, knowledge, and learning, there are several key principles that we work toward in all of our programs. Our work is embedded in the principle that all women have a right to self-determination, bodily integrity, and non-discrimination in the receipt of services. We work across the humanitarian response to development continuum, recognizing that threats to women's reproductive and maternal health often are greatest in conflict and emergency settings, and that many countries swing from development to emergency and back again. We work to overcome barriers to service utilization and health system quality, addressing underlying causes that often are based in social and gender relationships, as well as the relationships between citizens and service providers. Overcoming these barriers requires that we work not only in the technical areas of SRMH, but also in cross-cutting areas such as women's empowerment. And finally, we seek to rigorously document the results of our work to inform programming by CARE and others, as well as to support advocacy. The space where we try to work is at the intersection of the three circles shown in this slide. Participation and inclusion focuses on women and couples being empowered to claim their reproductive rights while also addressing inequitable gender and social norms that may restrict a woman's ability to access health services. Quality services refers not only to healthcare providers who are trained, supervised, and equipped, but also to workers who are empowered and who are responsive to the needs of clients. Transparency and accountability are achieved through the creation of spaces for dialogue and negotiation between citizens and service providers that are inclusive and where mutual responsibility and accountability contribute to ongoing improvements in service quality and utilization. And all of this, of course, must occur within a broader environment of adequate funding and supportive policies. I mentioned earlier that CARE works across the emergency to development continuum, and I'd like to expand on this as the link between family planning and maternal health is especially important in emergencies. In 2011, an estimated 61 million people were affected by humanitarian crises, and this number is expected to increase as populations rise, as the effects of climate change continue to expand, and as conflict continues to spread. UNFPA estimates that about a quarter of maternal deaths in refugee settings are from complications of unsafe abortion, and both mothers and children face significant risks from unwanted pregnancies that go to term. To address this problem, CARE has received some support from a large anonymous donor to implement a program that focuses on increasing voluntary family planning and providing post-abortion care in several core countries that are shown on this slide, as well as additional countries as the need arises. Working with governments and local partners, we've adapted the Population Council's balanced counseling strategy to increase the ability of healthcare workers to provide client-centered counseling that ensures that family planning is voluntary and clients have meaningful choices of family planning methods, including long-acting methods. We provide training, ongoing quality improvement to integrate family planning with post-abortion care and ensure the availability of family planning methods. Contextually appropriate strategies are used to address social barriers. For example, in Chad, strong engagement of men and religious leaders has helped to reduce social barriers and to increase community support. Results so far have been very positive, with significant uptake of family planning, particularly long-acting methods across all three countries, as well as high acceptance of family planning post-abortion. Moving from the humanitarian to the development setting, one approach that is taken in many of the countries where we work is the integration of maternal health and family planning programs. This makes sense given the same range of providers for both services from the community to the facility, the appropriateness of messaging on both across the continuum from before pregnancy to postpartum, the similar health system strengthening issues, and many of the same social and gender barriers. As we work across the three areas highlighted earlier, quality services, participation and inclusion, and accountability and transparency, we try to include innovative and cross-cutting strategies to increase effectiveness. And in the rest of this presentation, I'd like to share some of the approaches we've been implementing in integrated programming in Bihar, Mali, Malawi, and Benin. In Bihar, India, with funding from the Bill and Melinda Gates Foundation, we've worked with partners to implement an integrated family health initiative that addresses needs in reproductive, maternal, and newborn health, as well as in nutrition and immunization. Focusing primarily on community-based and first facility-level providers, we've worked with government to increase capabilities through on-site training and skill labs, and by developing a mobile phone-based system that includes a scheduler, reminders, algorithms, counseling messages and videos, and supervisory tools. And this ICT approach is currently being evaluated in a cluster randomized trial, so we'll be able to generate strong evidence for how it adds to the services that are being provided. Team building and integration of services are achieved by bringing together different health cadres that serve the same geographical area in subcenter level meetings monthly, where goals are set, planning is done, training provided, and problems solved. In a subset of this program area, we're also using specific team building approaches around leadership and incentives, and working with the Georgia Tech Department of Psychology to assess whether this improves motivation and coverage. While we don't yet have results for this independently evaluated cluster randomized trial, we look forward to learning whether these approaches also increase effectiveness. Ongoing monitoring through periodic household surveys and observation of labor, delivery, and postpartum care contributes to the identification of problems, to quality improvement systems, and to data-driven management. And finally, family planning is integrated throughout this program, with community-based workers providing counseling on postpartum family planning to women at birth preparedness and antenatal care visits. Family planning resource people are placed at public health centers and interact with women before and after delivery. And referrals are made to public and private sector providers for counseling and delivery of family planning methods. Mobile vans are being used by our private sector partners not only to increase access to providers who are trained in long-acting methods such as insertion of IUDs, but also this is a setting where the auxiliary nurse midwives can be trained in IUD insertion, increasing the number of providers who have the capabilities to provide these services. While our work in Bihar is primarily on the supply side, in other programs we've focused more on overcoming barriers to service utilization, one of the most important of which is inequitable gender and social norms and women's lack of empowerment. To address these challenges, we've worked in Mali, Ethiopia, Kenya, and Rwanda, integrating family planning with maternal health in Mali and with HIV in Kenya. Our approach begins with a gender analysis to identify inequalities and their social and structural causes. We then use an approach called social analysis and action, where through a number of exercises we stimulate reflection and questioning to surface, discuss, and potentially transform inequitable practices and norms. We begin this process with our own staff, who generally come from the communities where they work and therefore share the same beliefs. Finally, we've developed and validated a survey module that can be used to measure multiple domains of women's empowerment to determine whether our work has empowered women and in what areas, for example, self-efficacy, decision-making, mobility, spousal communication, social capital, and others. And then whether this empowerment was linked with improved reproductive and maternal health behaviors and outcomes. The work in Kenya and Ethiopia is part of a program called the Results Initiative, which was a 4-year program to assess the impacts of empowerment and increasing gender equity on family planning uptake. A recent evaluation, including interviews of both women and men, revealed that the program helped create an enabling environment by normalizing communication about family planning at the community and household levels, and by providing role models and social support for more equitable gender relations in the household. In both countries, based on women's reports, family planning uptake increased substantially. Cross-sectional analysis of the final evaluation survey also showed that family planning use was significantly associated with program exposure, and that exposure also was significantly associated with a belief in women's right to refuse sex, self-efficacy to use family planning, and more equitable household decision-making. A second key cross-cutting strategy has been participatory governance at the community level. Our experience suggests that developing inclusive and expanded places for dialogue and negotiation between communities, healthcare providers, and local government officials will improve delivery of quality, acceptable services. In maternal health, we emphasize mutual responsibility and accountability, recognizing that factors that contribute to poor outcome may occur either in the community or the healthcare system. One tool that we're using in Malawi and elsewhere is the Community Scorecard, an approach developed by Care Malawi over a decade ago. This methodology involves citizen representatives and service providers separately identifying problems and generating indicators of quality. Then they come together and develop a single list of indicators, rate the quality of services, and where problems are identified, generate and work to implement solutions. The only published report that I'm aware of assessing a similar report card methodology is from Uganda, where the approach was evaluated for a program that included 50 dispensaries in 9 districts, with results showing significant improvements in infant growth, service utilization, and under 5 mortality. So given the paucity of data, our program in Malawi currently is using a cluster randomized trial to assess the impacts of the community scorecard on maternal health, on family planning, and on PMTCT outcomes. So as we think about integration of maternal health and family planning, we recognize that this may occur not only through integrating service strengthening activities in the healthcare sector, but also by facilitating governance and accountability that drives solutions that are generated in the community and the healthcare system together. So in summary, I've briefly tried to share our approach to effective integrated family planning and maternal health programs, emphasizing the importance of working in the community to overcome barriers to the use of available health services, working with health systems to strengthen the continuum of care and improve quality, acceptability, and responsiveness, as well as working at the interface of the community and health system using participatory governance to build shared oversight, responsibility, and accountability. Thank you all very much.
Thank you so much, Ben, for sharing with us about the very important work that CARE is doing. I think on my resume I would like to be listed as large anonymous donor. But I do say on my resume I do have on it as recovering lawyer, and I'm happy that we have Jonathan Cooper, who I think is also a recovering lawyer. He is now the country director for Marie Stopes Uganda, which is a national NGO affiliate with MSI for the last 4 years. I'm just thrilled that he's been able to join us here today from Uganda to talk to us about really the very groundbreaking and incredibly successful work he's been able to achieve on behalf of MSI in the country, and I'm sure that lawyering comes into it at some degree. But thank you for joining us.
Oh, sorry. Oops. I'm not very familiar with the program that you have. That's the one. Okay. So from beginning right there. Sorry. There we go.
So, good afternoon. I feel a bit, I know I'm a Brit, but I feel a bit like a Ugandan village boy visiting Kampala for the first time. Wide-eyed with a big smile. I'm going to, we only have a short time, so I'm going to give you a whistle-stop tour of our services and how we've constructed our programme in Uganda with support from USAID and the British government in partnership. And I'm going to talk a bit about our impact and then give you a few stories. And I can't work the technology. There we go. Okay. So Murray Stopes Uganda is a local indigenous organisation with its own board, but it's affiliated to Murray Stopes International. And the way it works in Uganda is that we've received bilateral grants and we buy technical support from Murray Stopes International in London, Nairobi and through Washington. Murray Stopes International, for context, has been working since 1973, operates in 41 countries, 620 static clinics, 370 clinical outreach teams, 2,900 franchise providers, and I'll explain that a bit later, and 9,000 staff. In 2006, there were 4,000 staff. So the organisation has doubled in size over that period. Last year, I think 13.6 million women were protected by contraceptives provided by MSI globally. So down here, Murray Stopes, Uganda. So we've actually been operating in Uganda since 1996 when we socially marketed the first condom lifeguard in the country. Our core business is family planning, and we're currently, with the support of the US government and the British, operating in every district of Uganda. Uganda's about the size of California or the UK, and it has a population of 34 million. Which is growing at the rate of 3.2%, which means projections are that by 2050 there'll be 94 million Ugandans in Uganda. MSU, Murray Stopes Uganda, now provides 1 in 4 of the modern contraceptives. It's quite whizzy, isn't it? I love this presentation. I just get excited just looking at it. Here we have the service delivery channels, and I'll skip across first. Traditionally, Murray Stopes Uganda started with static clinics, providing general health and reproductive health services. And I wouldn't say we rob Peter to pay Paul, but the idea is that those who can afford to buy services should do, and then we use surpluses to subsidise our core provision of reproductive health and family planning. And we have 15 centres throughout Uganda, and the one which is supported by AID is a community health clinic in Moroto in Karamoja, where the contraceptive prevalence rate is 7.4 compared with a national of 26. And that's an arid region in the east of Karamoja. Those of you familiar with Kenya would know it as somewhere where the nomadic, the Maasai, would operate, who are very similar to the Karamojong. Shooting over here, our core business really has been mobile outreach. We have 25 clinical teams who move out 20 days a month, each of them visiting between 40 and 60 public health facilities, which mean they cover about 1,400 public health sites across Uganda. It's quite a large undertaking. I'm getting old, but I'm just exhausted going out for a day in the 4x4 with this team. There's a transport assistant, a doctor, 2 service providers. They go out often 2 hours over a Marin road to a remote public health facility. There'll be, this number of women up at the top right is pretty typical. They will have been mobilised through adverts and talk shows on the radio, which is the primary form of communication, and through our village health team members or community health workers. We provide group counselling, and those who want to take it further have individual counselling and sign a consent form before receiving a family planning method of their choice. Our focus is primarily on long-term and permanent methods, but we provide a voluntary choice of all methods of contraception, and that includes moon beads. So through outreach, we provide free services to the desperately poor. And I'll come on to talk about, the demographic profile of our clients. We've just started a new project in the Kampala slums where we have nurses or midwives travelling around on tuk-tuks, and their focus is the young at-risk populations, the most vulnerable. I was at a workshop, I think, with Craig, who's here from our office last week, and he was saying that he was talking to a lady who was saying, well, I'm a sex worker, I'm HIV positive, I'm 23, I have 4 children, they're all HIV positive, I need contraception, and I want to work with you to bring your services to the sex worker community who are heavily stigmatised within Kampala. And we realised that though we were concentrating on the bulk of our clients in the rural communities in Uganda, we still needed to focus on the city itself, particularly because of the growing trend towards urbanisation. Social franchising. Many of you will be familiar with 7-Eleven and McDonald's, Forte Hotels. The idea being that you harness the power of the private sector through accreditation, training and branding. So the Blue Star franchise, I think we operate Blue Star in over 10 countries worldwide. I don't think anybody has been as ambitious or stupid enough to try and roll out 450 franchises in 18 months, which we have across Uganda. But, 60% of Ugandans go to the private sector first as a first port of call for healthcare. And that's because of the parlous state of the public health system. And there are 10,000 drug shops, clinics, private providers around the country. And we use a process of mapping, selection, accreditation using very strict quality protocols and training. And under the Ministry of Health curriculum, it takes 2 weeks to train in long-term and permanent methods of contraception. And that's normally, if you like, a cost barrier and one of the biggest costs in a program of this kind. But once you've set up a franchise network, and there's a quality guarantee that when anybody walks into one of the Blue Stars, they're going to get a Mary Stopes quality of care. Once you've set it up, it's actually a cost-effective means of delivering services. And since we've set up the Blue Star network, now Gates have funded cervical cancer screening and treatment through Blue Star. And you could add other services like HIV counselling and testing quite easily. Linked to, and I'm going to come on to talk about vouchers later on, voucher distribution, but we do have a family planning voucher program. We're selling 240,000 family planning vouchers to 2015. And I think we do have a copy of a voucher around somewhere. It's up in the top right. A woman for 75 cents who we deem to be poor using a poverty grading tool can buy the voucher and have it redeemed at one of our Blue Star accredited facilities, which means she goes there, she receives counselling, a family planning method of her choice, and she can have a second visit for review and treatment of a side effect or a complication, and a third visit for removal. The private provider provides the service without demanding money, but then claims reimbursement from Mary Stopes Uganda as a voucher management agent. And that's a program, or we've been running voucher programs in Uganda for since 2004, I think. I love it. I think it's great because rather than an input-based program where you pump in, millions or billions of dollars and you have a budget which says, well, maybe we'll treat this many people over the course of the program, with a fair wind and if we're lucky and everything else. With this program, you only actually reimburse per service provided. So you can actually determine how many services you're going to provide, approximate the cost, and you know what the quality is going to be because you've accredited the network. So it's actually, I think it's a fantastic program. I would, of course. I'm the country director, so I'm responsible, but I do. So at the bottom right, we have a huge network of village health team members. We work through over 2,000 VHTs. They're classified as Health Centre 1 in Uganda. And they're typically respected members of the community who have some capacity for counselling and providing health education and some services. They sell our vouchers, they mobilise people to go to outreach sites and to Blue Star facilities. But we've also, through task shifting in Uganda or task sharing, they actually provide short-term methods of contraception, including injectables, under a scheme which was piloted with research from FHI 360 in country. And we're really excited to get the support of the Ministry of Health in that endeavour. And it's important because these are the guys who are always there in the communities. So as many of them who can actually counsel and provide contraception, the better. And of course, if they're well-resourced, they can also refer people for long-term and permanent methods. When the outreach team comes into town, they can sell a voucher for a Blue Star facility. So the kind of the glue within the ecosystem, if to extend a metaphor, probably too far. The bottom left-hand side, we have social marketing. I said we've been selling condoms. I wish I had the statistic, but since 1996, we've been, if you like, the people's favourite condom provider. And in fact, we've had no donor support since 2007. So we rely totally on, we receive donated commodities from UNFPA and we reinvest the revenue generated into distribution and marketing and just about keep it on the road. Our hotline, we're really excited about this, kind of sits between our service channels, and it's a toll-free number. We give the card to all of our clients and we advertise the number on the radio, so anybody can call at any time and they can talk about family planning, contraception, how it works with HIV, and be referred for services to a Blue Star, to an outreach facility, to a public facility, to our partners. There are so many myths and misconceptions in the villages around contraception. We know the unmet need for family planning in Uganda is 34% of women of reproductive age, which is about 1.8 million women. One statistic I heard the other day is if we met the unmet need, would reduce maternal mortality by a third immediately. And so when you provide quality education and counselling, women are turned on to family planning. But many women believe, because there's the lack of basic understanding of anatomy, if you put an IUD in the uterus, it floats through the body and gives you a brain hemorrhage, it causes cancer, it comes out somewhere else. And I've heard that so many times in rural Uganda. And people also need to receive advice after service because many women bleed after receiving a hormonal contraception. And that could easily be solved through the administration of ibuprofen or OCPs. So the hotline's critical, and I can see it's expanding over time and will become increasingly important as we continue to socially market contraceptives. And those contraceptives could expand with medical technology to things like spray-on protection, etc. So whizzing across, to look at the Healthy Baby Voucher Programme. This is a programme that was born out of a World Bank and KfW initiative, which we ran between 2006 and 2010, and which is now funded through the SHOPS programme and Abt Associates. It's very similar to the voucher I described before, but it entitles the user to 4 antenatal visits, safe delivery and postnatal care. and they buy the voucher for 3,000 Uganda shillings, which is about $1.25. And as I said before, it's a very cost-effective way of directing a subsidy. And in the future, one can see that this kind of scheme would be an effective way of directing a subsidy from the Ugandan taxpayer as part of a national health insurance programme, in that a woman's prepaying a premium for protection, and you have an accredited provider network which is contracted in by the government to provide services on its behalf. And that's kind of the future, as far as I'm concerned, of these kind of voucher programmes. And it's been operating in the 4 districts of Western Uganda. You can see there, we call them the 4Ks, which have the most dire maternal mortality statistics, and as part of the Saving Mothers Giving Life programme. And we work with Every Mother Counts in those districts. And it has a very ambitious goal of reducing maternal mortality by 50% in a year, and we're still waiting for the outcome. So whizzing right in there. So we see the objectives of the programme: increase poor women's access to obstetric care in private facilities, improve quality obstetric care in the private sector. Describing again, it's the kind of 7-Eleven model. When you go to 7-Eleven, you know what to expect. If you go to a Forte, you know you're going to get a comfortable night's sleep. If you go to an accredited voucher service provider or a Blue Star, you know you're going to get a certain quality of service. So we work with the Association of Ugandan Obstetricians and Gynecologists, who provide the training, monitoring and accreditation, but we also work very closely with the district health teams. There's a strong public-private ethos in Uganda, and there's a policy which has just been passed by the Ministry of Health. So rather than push us away, these days the Ministry of Health is very careful to derive sort of complementarity of service provision. So even though we're working through the private sector, we try to include the Ministry of Health and the district health teams. We can see the ANC visits. We have malaria treatment. We've just included PMTCT as part of antenatal care. Safe delivery, high quality facilities with skilled attendants, care in case of complications. And typically a woman would go to a BMOC initially close to her home, and she can... one of the innovations in this program is that we created a transport voucher or a boda voucher. So typically a mother, I know it sounds horrifying here in Washington, but a woman out there in the villages who's got no other way, like the one we saw in the film, who can't travel to a facility, can call the local boda voucher driver on a mobile phone. They'll come and pick her up. She'll sit on the back of the motorbike and be transported to a facility to receive safe delivery services, often in the middle of the night. And if there's a complication, she's entitled to free referral, often to a CMOP facility. We've also added family planning as part of the phase 2 of this program, which is going to run from 2012-2014. So under this program, which is funded by AID, we distributed 10,888 vouchers. ANC visits, we had an uptake of 22,693. If you look at the chart, you often have women coming for, probably 89% of the voucher holders come for ANC1, and that dips down to about 25-30% for ANC4, and then we get about 13% coming for postnatal care. But the redemption rate for actual safe delivery is around 70%. So we've been very successful. We've actually overshot our targets, which were set on the basis of the previous program. We think that's because of some of the innovations around BCC, sensitisation, and the transport voucher. Quality of care, we've achieved our targets there. I'm very conscious of time. I'm dwelling a bit too much here, but shooting down. Looking at impact for family planning. So you can see, and this is only to 2011. I wish we had the data for 2012. But you can see roughly Murray Stopes Uganda's contribution to the contraceptive prevalence rate up there on the top right in the light blue, which is about a third of the total. So we contributed around a third of the national growth in modern contraceptive prevalence between 2006 and 2011. We've seen skyrocketing prevalence of implants, and it continues. We were quite worried about it at first. We wondered whether we were doing something wrong, whether it was because of satisfied users. Were we patronising women by expecting them to take IUDs or tubal ligations? And whilst I think 1 in 50 family planning users in 2006 used an implant, now it's 1 in 11. And we provide 3/4 of the implants in Uganda. We have seen a trend back towards IUDs after implementing some new initiatives. We now counsel for IUDs first, using the old marketing technique that you remember what you hear first. We make sure that doctors and clinical officers are involved in counselling so people have confidence in the provision of IUDs and tubal ligations. And we also make sure we provide a very strictly private area for women to receive an IUD, because obviously it's perceived as more intrusive and invasive. And also emphasise the benefits of an IUD being non-hormonal, the fact that you return to fertility immediately upon receipt. So whilst we initially had a ratio of about 1 implant to 11 IUDs, that's now come down to about 1 in 8 over the course of the last couple of years. The Healthy Baby Programme, we can see we've been successful. We've actually had a higher, in geeky terms, in voucher programs, redemption rate's really important, because you can sell as many vouchers as you like, but you want people to use them, and you want them to adhere to a program of services, particularly in the continuum of obstetric care. So the Population Council did an impact evaluation of the precursor to the SHOPS programme, our first Healthy Baby Voucher programme, and it was very encouraging. So more women from poorest households used the Healthy Baby Voucher than from better off households. There was a shift, as you'd expect, from home to facility-based deliveries. And also we looked beyond the voucher user to the women in the communities amidst the voucher users, and found that there was a significant reduction in the likelihood of paying out of pocket for private facility births in villages with a voucher client as opposed to villages with no voucher client. So there was an after effect to use of vouchers. One of the things which needs to be clarified is that when private clinics receive voucher income, so they receive reimbursements, they can predict that they're going to have a turnover of clients and therefore generate a certain amount of money. And we've found that many of our voucher service providers actually reinvest in their own facilities, building theatres, new maternity wards, employing more staff. And we see the percentages there, the highest being construction, roughly about 25%, renovations and repair, human resources, 50% in 2009 at the start of the programme, and then down to 33% in 2011. So we've doubled our impact since 2009. We're now saving, we estimate, 2 lives a day by reducing unwanted pregnancies for all the reasons we heard before. In 2012, 600,000 women were protected with a Marie Stopes Uganda contraceptive, and we averted 259,703 pregnancies. And obviously there are savings to the healthcare system by preventing unwanted pregnancies, and we estimate the figure to be £12 million in 2012. And for those who understand it, disability adjusted life years averted 313,000 in 2012. So what does it mean to real people beyond this room? in the villages of Uganda. So looking at, and this seems an extraordinary story, but it's fairly typical in my experience in Uganda. So we interviewed a family of 3 generations. Unia, 90 years old. She didn't have the opportunity, of course, of using family planning. Her daughter, Pelusi, 47 years old, didn't use contraceptives because of negative rumours she had heard about risks and side effects. And she gave birth 15 times and lost 3 children before choosing to have an IUD fitted by an MSI outreach team 2 years ago. And Unia's great-granddaughter, Immaculate, she's 17 years old, and she's decided to wait until she's older to have children. And because of regular visits by the MSI outreach team, she knows where to access the contraceptive she needs to make that decision. Ruth is, again, a very typical user of a Healthy Baby Voucher. She attended the ANC visits at a private health facility she would never have been able to afford to visit. She was expecting twins. They were poorly positioned for a safe natural birth, so she was referred, rather than like the lady we saw in the film in Tanzania, to Kabarole Hospital for caesarean delivery. And the voucher covered transportation, and Ruth safely delivered her twins. And I think sometimes, you know, the thing which motivates me much more than I ever was as a lawyer working for the Financial Services Authority and all of these places, is I see cause and effect. I see where the dollars go, and it goes to service delivery and it goes to health impact. And if you haven't, you should come out to rural Uganda or to another country like this and talk to women. You see all of your efforts and all of our work is having meaningful results. And it's not desperate. You know, we are seeing contraceptive prevalence rate pick up. We did see President Museveni at the London Family Planning Summit last year making a pledge to reduce unmet need to 10% by 2020. The Ministry of Health is, you know, it's undermined, it lacks capacity, there are institutional breaks and blocks preventing it doing work, but it wants to support family planning and maternal and child health care, and we need to support them to help them with this work. Thank you.
Thank you so much, John. We have just a little bit of time for questions. I'm looking at Sandeep in a few minutes. We can take a few questions, but the good news is that we can then go to our reception where you'll be able to speak directly with our wonderful panelists. That was a really rich presentation, and I want to thank all of you so much. We have roving microphones, I believe, and I'd just like you to ask if you could say your name and your organization, because again, we're being webcast, and I see in the back row, green.
Hi, my name is Anna Forbes, and I'm an independent consultant, so I don't have one organization per se. I wanted to ask a question in light of the research data we got from Heffron in The Lancet in 2011 about the impact that DMPA may be having on HIV risk. Her data showed that there's a possibility that it may increase a woman's risk of transmitting HIV if she's positive, and it may increase her risk of acquiring HIV if she's HIV negative, and yet, of course, DMPA is still very frequently used as an injectable contraceptive. I was interested particularly in the last speaker's comments about the IUD use rates changing somewhat, and I wondered if all or both or several of you could talk about whether there's any awareness around this potential risk with DMPA, whether it is changing patterns of use of injectable contraception, and what you think is likely to happen around that.
Thank you. I'm not an expert, but I do recall that that study was, I think there's fairly strong evidence that there is no connection between the two. So I wouldn't use a term as strong as discredited, but certainly our position is that people should continue to use DPMA where appropriate.
Why don't I connect with you after the meeting, and I can put you in touch with the people in our office who have worked on that, and you'll get all the latest information.
Okay, thank you. Front row here.
Do you want to comment, Maggie?
We're actually, can you wait for the mic, please?
My name is Maggie Farrell. I work at USAID in the Office of Population and Reproductive Health. We're actually crafting communications around that and the talking points that came out from that. And actually with MSI, I think we were waiting for WHO to do that, but now it's being done, I think, through our Behavior Change Communication Project. And I don't know if Tabitha or Hope is here, because they could speak better to this than I could. And then we hope to have a launch, and we're going to work with Marie Stopes International in the countries in sub-Saharan Africa where there's high prevalence, high generalized prevalence. And we're going to be rolling out a counseling model with messages based on this communications and field testing that. And then Engender Health is a sub on the Marie Stopes International, Strengthening International Family Planning Organization's centrally funded AID project that I am actually the manager for, technical manager on. And so we're going to be field testing those, and then we're hoping to spread those to ministries of health, and we'll be involved with the ministries in the country to roll those out. But that's part of our work plan for this year. Thank you.
John.
Thank you, John Townsend, Population Council. I love the whizzy presentation. One question, Maureen mentioned post-abortion care, and with the amount of both miscarriages and undoubtedly induced abortion in Uganda, where it's illegal, what is the experience? I thought we'd see some post-abortion services in terms of figures. You guys do a marvelous job, terrific quality of care. Now, I'm wondering, in a place like MSI in Uganda, what's been the experience with post-abortion services?
Of course, post-abortion care is very important. I mean, Guttmacher Institute has done various studies around, 300,000 unsafe abortions every year in Uganda. I think 9,000 complications, like 1,000 deaths. And of course, in our static clinics, we do have people coming in with complications related to unsafe abortions, and we do provide post-abortion care services. From our perspective, we know that we have to act within the law, and that's it, really. Situation, yeah.
But Sarah, let me just clarify for everybody that USAID does support post-abortion care. We do not support abortion services.
Yep.
But we do support post-abortion care. We support post-abortion care. It always includes family planning to prevent repeat abortions. So sometimes there is confusion over this issue.
Yeah.
But John said I did mention our work in post-abortion care in my introductory remarks. And sounds like you could use the decentralized model that I spoke about. And we're very proud of this decentralized post-abortion care model that has moved services from the tertiary hospitals to the clinics and posts in the rural areas. So I also just wanted to let people know that we have we funded one study, and the study was done in Bangladesh, and it found that when births are spaced too close together, and in this instance, less than 6 months. In Bangladesh, there was a 7.5 increased likelihood of induced abortion and a 3.3 likelihood, increased likelihood of miscarriage, and a 1.6 increased likelihood of stillbirth. So there are these connections, and obviously women are confronted with the need for family planning services in these rural areas, and we hope that the decentralized post-abortion care model will be adopted, and we'd love to talk to you about it.
Okay, right there.
Thank you very much for your presentations. My name is Cici Fedope, and I'm also an independent consultant. Both in Uganda and for CARE, would you talk a little bit about how you interact with the government? What is the government of Uganda, the government in the countries where you work? How do they contribute to the processes, and how are you able to scale up the programs that you're doing throughout the countries? Thank you.
In CARES programs, we work through the government, through the public health system, as well as with private sector providers, but most of our work is certainly in the public sector. One of the approaches that we take working with the government is not only to include the government in all of the components, to train providers, to strengthen government systems, etc., but then also to engage the government in the learning around the program. So that, as an example, in Peru, we implemented a maternal health program which demonstrated a 49% decrease in maternal mortality and a significant increase in met need for emergency obstetric care, primarily not just through strengthening the health system, but also by improving the acceptability and the cultural acceptability of care. When we documented those results and shared it with the government, there was a decision made by the government of Peru to expand this model nationwide, so really to scale it up. And now CARE is working in Peru on governance and accountability to hold the government responsible for making that commitment. In Bangladesh also, by documenting the impact of a community support system model, the government has now decided to scale up that approach to 13,500 community clinics nationwide. So another example of how working with the government has moved from a program in several districts to national scale.
John, do you want to add to that from MSI's experience?
So we have a strong working relationship with the government of Uganda, primarily because we're providing services in 1,400 of their public health sites. And we're now going to be extending our voucher program to the private wings of public hospitals. You know, it's not without its challenges. And because of the low rates of pay within the Ministry of Health, there's a turnover of staff, and sometimes the quality of deliberation can be complicated and challenging. But in designing any of our programs, we first go through the technical people in the reproductive health division through to the Director General, and often have meetings with the Minister where we can. And we adapt our programming accordingly. And I think we do have a very strong collaborative approach with USAID and the British government, as well as with other stakeholders. I should say we have started a Uganda Family Planning Consortium, which is an association for advocacy and coordination, and includes Population Services International, Pathfinder, Reproductive Health Uganda, which is the IPPF affiliate, and all the big players, all the big service providers. And we meet quarterly, and we've managed to get funding for a coordinator, and the coordinator is often called into the Ministry of Health and asks and answers questions on behalf of the group of private not-for-profits, and that's extremely helpful to us. And one of the things which the Ministry of Health is very concerned about is coordination, because you don't want outreach teams from different organisations bumping into each other in one particular district of the country, given the size of the unmet need. And technology is helping us, things like GIS mapping, but it's something the Ministry of Health is very conscious of because it only has very limited resources. So trying to provide that sort of coordinating capacity for the Ministry of Health, so it doesn't have to speak to 6 or 7 organisations, but just to one coordinator, I think is very useful.
Sarah, if it's okay, can I make mine the last question?
Oh, sure.
Sandeep. As Sarah mentioned too, if you do have some more questions, we do have a reception across the hall. But Jessica, I was hoping that you could take a moment and talk to us a little bit about the rollout of the film, where it's been shown. Has it been in any film festivals? And in particular, I'm interested in the international response to it. Have some of the women who've been in the film seen the piece itself?
Sure. Yes. So in true documentary fashion, I think all the women who were featured in the film have seen it and have had experienced ripple effects from it. The film actually came out in 2009 or 2010, so it predates me at Every Mother Counts, but there's a whole list on our website. It was at the Tribeca Film Festival and a number of other festivals, and there's been a great reaction to the film, but it's all on our website if you're interested.
Well, I want to thank all of our panelists and again the Wilson Center for hosting us here today, and thank you all for your wonderful remarks. Please join us for a reception out in the hall, and you'll be able to talk to all of our panelists up close and personal. So thank you so much.